Welcome back to the equine anatomy lectures. We talked about three main topics so far. Talked about the head, talked about the neck, and we've talked about the thorax. This lecture, we will talk about the equine abdomen, a very important topic. I'd just like to remind all of you of the email address below. If you have any comments or concerns, questions or anything, could you please just email me and I'll be more than happy to respond to you. As always, I start with the significance of the topic that I'm going to be discussing. So I'm going to be talking about why should we understand the abdominal cavity of the equine patient. Why do we have to understand the gastrointestinal tract within it and the other organs and structures? How are we going to get into the abdominal cavity? What are the layers, the muscles, the fascia, and all of the procedures that can be performed on that structure. Now, the second point, I'll talk about the abdominal wall. I'm talking about the fascia and the muscles. So I'm going to be dissecting all of this. And the third thing I'm going to be talking about is abdominal topography, or the different organs and systems that are located or that they reside in the abdominal cavity. And mainly we're talking about the gastrointestinal tract because it occupies most of the abdominal cavity in horses, and that's basically will be the conclusion of this topic when I talk about two very important clinical entities, and these are the colic and rectal tears, very important clinically. So why should we study the abdominal cavity? Well, we have a number of clinical cases that we will see. First of all, as I mentioned earlier, if you're working in a racehorse track, you will see that over 70 or 80% of the horses suffer from gastric ulcers. Horses are pretty competitive, and they have a tendency to have gastric ulcers due to a number of reasons, and we'll talk about that when we talk about gastric ulcers. But on the left-hand side picture, you will see a normal stomach, a normal equine stomach, and the equine stomach, as I also mentioned in previous lectures in anatomy and also in the lectures of the gastrointestinal physiology, consists of two parts, the non-glandular area and a glandular area separated by what we call the margo plicatus that separates the non-glandular from the glandular regions. On the right-hand side picture here, on the other hand, we see another couple or three ulcerative lesions in the non-glandular area of the stomach. So this case is very, very, very common in equine, and that's why we should understand the gastrointestinal tract, the anatomy of the gut, and as well as the anatomy of the abdominal cavity. We will see a number of clinical cases like this. This is a picture that shows the two parts of the gastrointestinal tract. One is normal. We can see the pinkish color here, and we can see the abnormal tissue here, which is pretty dark and incarcerated. And we will see these cases when we open the abdomen. We encounter a number of clinical cases that affect the gastrointestinal tract. One of them is incarceration, or sometimes twisting. Part of the gut twists and blocks the blood supply to some parts of the gastrointestinal tract. In this case, it's the small intestine. And for that, and colic is one of the most important cases in equine medicine and surgery. So we have to understand the anatomy of the abdominal cavity, since the majority of the gastrointestinal tract resides in the abdominal cavity. So that's another reason why we need to understand the anatomy of this structure. This is one of the clinical cases that we sometimes encounter. It's called colon impaction. This is the large colon in an equine. You can see how big it is because it is impacted and the food's not moving easily in the gastrointestinal tract for a number of reasons. We'll talk about it later. But this will show you how important studying the different parts of the gastrointestinal tract and how important to study the anatomy of the abdominal cavity, both the wall and also the abdominal organs, in order for us to be able to fix the problem. So this is a very important reason for us to understand and study the anatomy of the abdominal cavity in equine. One of the most devastating cases in equine is rectal tears. We do rectal palpation pretty frequently in equine medicine and surgery for diagnostic and for therapeutic reasons, also for pregnancy diagnosis. And so on the right hand side picture here, you will see that sometimes due to the inexperienced practitioner, or sometimes they're in a hurry or something, they will rupture parts, layers of the of the rectum, or sometimes they will rupture the whole rectum, all of them, perforating the whole structure, and you will see blood on the rectal sleeve after they're done. This is a nightmare for the equine practitioner, one of the most devastating cases, because it's a liability case. They can take the veterinarian to court and cause a lot of problems, and also you can lose the animal because of it. And so that's another reason why we need to understand the anatomy of the abdominal cavity and the rest of the organs inside this cavity. And so with these examples, I hope I've illustrated to all of you that studying the anatomy of the abdominal cavity is a very important thing to do. And so during this lecture, I will discuss the abdominal wall, the different layers that will get us to the abdominal wall, the fascia, and then the abdominal muscles. And then after that, we'll talk about the abdominal organs. As I mentioned, most of them are basically the gastrointestinal tract and relations of this system with other structures such as the kidneys and things like that. The very first thing that we will encounter is the superficial thoracic vein, and I mentioned that before. You can see the superficial thoracic vein pretty clearly here on the lateral abdominal wall ventrally, and this is one of the alternative side for venipuncture in equine. Sometimes, if the jugular veins are not patent or are not usable for putting a catheter, say for fluids, or sometimes you need more catheters to be placed in the equine patient to put more fluids in a pretty short period of time. The superficial thoracic vein or the spur vein can be used as an alternative site for venipuncture, as I mentioned earlier. When we remove the skin of the abdominal wall, we will find a group of lymph nodes that are called subiliac lymph nodes. They are located dorsal to the stifle joint and cranial to the tensor fasciae lata muscle. This subiliac lymph nodes gives efference to the lateral iliac lymph nodes in the horse. But we have to remember them. When we remove the skin, they drain the thigh and part of the abdominal wall and things like that. But their location is dorsal to the stifle and cranial to the tensor fascia lata. Cranial to the tensor fascia lata. Next is the superficial fascia. And the superficial fascia is basically, as I mentioned, in the thoracic cavity, or in the neck, and also in the thoracic cavity, that they basically cover the muscles. So they are loose connective tissue. They're weak. They tear apart pretty easily. But what we are concerned about is what we will call the deep fascia. The deep fascia is the strong, dense, regular connective tissue that actually uh, um, has a different name in the abdominal wall. It's called abdominal tunic. Abdominal tunic, it's pretty strong, and it covers basically two very important areas that can be used for surgical manipulation in the horse. And those are the paralumbar fossa and the flank region. Paralumbar fossa and the flank region. These areas are used pretty frequently to enter the abdominal cavity rather than to do a ventral midline ciliotomy, which is basically through the linea alba. Here you will have two different surgical sites that can be utilized in the standing horse, in the standing patient, through the paralumbar fossa and through the flank region. These are very important, and they are covered by the deep fascia, or what we call the abdominal tunic. Once you enter these areas, once you incise the abdominal tunic, it must be sutured because it's a pretty strong connective tissue, and it's a holding layer. It's pretty strong, so therefore you must suture it. That's a very important thing to remember. This is the paralumbar fossa. We utilize that on the right hand side of the animal, and a cranial to the tuber coxae, and caudal to the last rib, ventral to the transverse process of the lumbar vertebra. And here we utilize this site for a case that's called cecal tympany, accumulation of air in the cecum. Accumulation of air in the cecum. We call that cecal tympany. In the cecal tympany, and the cecum is located, or at least the base of the cecum is located on the right paralumbar fossa, and that's what we utilize the incision for, to deflate the cecum through a technique called the trocar and cannula. So we use a trocar and cannula type an instrument to basically stab the horse in the right paralumbar region to deflate the cecum if there is excessive air accumulating and excessive gases in the cecum. We call that cecal tympany. And again, the site is called the paralumbar fossa, which is located cranial to the tuber coxae and caudal to the last rib, ventral to the transverse processes of the lumbar vertebra. These are the landmarks to do a paralumbar fossa incision. This is where you stab the patient with the trocar and cannula to basically deflate the cecum. Of course, before you do that, the whole thing is going to be, the whole area is going to be surgically prepped and clipped, or clipped and prepped, and then the trocar and the cannula should be sterilized, and everything should be sterilized. Now this is basically to explain to you where this area is, and why is it important for us to understand the paralumbar fossa incision. This is the cecum, and this is the base of the cecum. Now, when the cecum is inflated with gases, this comma shape structure will be straightened out. So this piece will become here, and the apex and the body will dive cranially and ventrally. Cranially and ventrally. This is a case of cecal tympany. Now, when the base becomes here in the paralumbar fossa, again cranial to the tuber coxae and caudal to the last rib, ventral to the transverse processes of the lumbar vertebra, that is the area where we need to utilize for the trocar and cannula technique to deflate the cecum from excessive gas accumulation. This is another picture of a live horse, if you will, and it shows the right paralumbar fossa. Again, before the surgery, everything must be clipped and prepped surgically, and then the instruments should be completely sterilized. And this is a surgery that needs to be done pretty carefully because it's done in the standing horse, and local anesthesia, of course, heavy tranquilization, and you're going to enter the abdominal cavity, and then you're going to enter the gastrointestinal tract, which is a contaminated area, so you don't want to cause peritonitis to the animal. This is the trocar and cannula, basically. As you can see here, when you prep the area, and this will be sterilized, basically, you stab the animal on the right hand side, and then you leave the cannula inside. You take the trocar out, and so the air will get in, out from the cannula, basically, and that's how you're gonna deflate and relieve the pressure in the cecum of the horse. Another incision in that we've talked about, that's covering that area, is with the abdominal tunic, is the flank incision. Flank incision is a very important area that can be utilized in a couple of surgeries. One is a ovariohysterectomy or ovariectomy in mares, granulosa cell tumors, things like that. We remove, and then we remove those tumors. And then another indication for this incision is loop colostomy. Loop colostomy is basically a part of the colon that's attached to the abdominal wall in cases of rectal tears or damage to the colon. So you deviate the feces direction from the rectum. You direct it toward the flank area. So the animal will start defecating from this area, basically. That's again in cases of rectal tear, which we will be talking about later. But the main thing is to remember that the flank incision here also is important for these cases, and this area is covered with the abdominal tunic, which is the deep fascia, and this must be sutured because it's a holding layer. It's a strong layer. Ovariectomy, as I mentioned earlier, you can utilize laparoscopy through the flank region, and then you can take the ovaries, or sometimes if they're normal or abnormal, granulosa cell tumors and things like that, or any other lesions, to take the ovaries for. Same thing, you have an opening here. You can take the ovaries through it, or you can take any lesions through it. But the main thing, again, from an anatomical standpoint, you need to suture the abdominal tunic, which is a deep fascia. You will learn about these surgeries intensely in the equine surgery course, but here we need to remember the areas, flank incision and paralumbar fossa, as well as the abdominal tunic, which is a holding layer, a very strong layer that needs to be sutured. This is loop colostomy, as I mentioned earlier, and that's basically taking part of the colon and put it through the abdominal wall in the flank region. You suture it to the abdominal wall so that the feces or the the end digested material will come through this opening from the flank. So there is no rectum anymore, because there is rectal tear that happened in these horses. So this is a permanent procedure, basically. Fistula implantation. You can implant fistulas basically in the flank area to put it in the cecum to collect microflora, bacteria like the donor cows that we talked about in the GI physiology. This is a donor horse that you can actually take microflora from this horse and put it in the cecum of other horses which have some fermentation problems. They don't ferment food pretty well. This is the tool that you're going to use, the fistula, that you're going to be putting this in the fistula that you created, and take the microflora from. So that's basically another surgery that you can utilize for the flank region. This is the end product for the fistula basically, and again you utilize the flank incision, and again you have to suture the deep fascia, which is called the abdominal tunic. Why? Because it's a very strong connective tissue, regular and dense, and it's a holding layer, and we need that layer to hold the abdominal viscera inside. We close the flank incision, as you can see, with staplers after we suture the abdominal tunic in both cases, whether it's one incision or a couple incisions, laparoscopy or actual classical methods. You utilize both basically. Now we reach the third point in our discussion, and that is the muscles of the abdominal wall. The muscles of the abdominal wall. And here we have to remember that those muscles are extremely important, and we will talk about them one by one, and we will talk about the clinical relevance of each one of them as we talk about that particular muscle. And the first muscle, after we take that abdominal tunic that we talked about with the two incisions, the paralumbar fossa and the flank incision, the first muscle that we need to pay attention to is the external abdominal oblique. It's number 10 in this slide, and this is number 10, and it's cut here so you can see the rest of it in this area. But this is the continuity of it. It covers the whole area here. The whole area, but this is, again, as I mentioned, it's cut just for the purpose of illustration. So it's number 10 here, the external abdominal oblique. And the external abdominal oblique is followed after that by the internal abdominal oblique. Internal abdominal oblique here, which is number 14 and 19. Right here. And then after that you have the transverse abdominis muscle here, and then finally you will have the rectus abdominis. Rectus abdominis, number 18. Rectus abdominis. So we have 4 muscles in the abdominal wall of the equine patient. Number 1 is the external abdominal oblique, internal abdominal oblique, transverse abdominis, and the rectus abdominis. Now we will talk about each of these muscles separately and the clinical relevance for each of these muscles. So these are the 4 muscles: external abdominal oblique, internal abdominal oblique, transverse abdominis, and rectus abdominis. The external abdominal oblique originates from the lateral surface of the ribs and the thoraco-lumbar fascia. Thoraco-lumbar fascia. So the lateral surface of the ribs and the thoraco-lumbar fascia. It inserts in 4 different areas. In the Tuber Coxae, 1. In the pelvic tendon, we'll see in a second when we open the wall of the abdominal cavity, prepubic tendon again, and also in the linea alba. So it inserts the external abdominal oblique, inserts in 4 places: Tuber Coxae, pelvic tendon, prepubic tendon, and linea alba. Please realize the direction of the muscles of the external abdominal oblique. They are going caudally and ventrally. This is the head of the horse. This is the tail, head and tail, cranial, and caudal. So the muscle fibers travels caudally and ventrally. Caudally and ventrally. This is number 1 thing that I would like you to remember. The second thing I would like you to remember is the fact that there is a line of separation between the muscle part of the external abdominal oblique and the tendinous part of the external abdominal oblique. This is the line that separates the 2 structures, the muscle structure and the tendon structure, the sheet-like structure and the muscle structure. This is the line that separates between them. We will talk about this line pretty soon, but this is the second thing that I want you to remember. So the first thing is that the muscle fibers go caudally and ventrally. The second thing is that there is a line that separates the muscle part of the muscle from the tendinous sheet-like structure part of the muscle. The third thing I would like you to remember is that the insertion of the external abdominal oblique occurs in 4 places, two of which will be utilized as the origin for the next muscle to come, which is the internal abdominal oblique. So the insertion of the external abdominal, 2 of the insertions sites for the external abdominal oblique are the origin for the internal abdominal oblique. This becomes very important, and I will explain that how. This is the prepubic tendon. This is an open abdominal cavity, and you are looking at the ventral aspect of the abdominal wall. So you're looking dorso-ventrally now. Dorso-ventrally. You're looking from the back to the abdomen, and you will see the prepubic tendon where the insertion of the external abdominal oblique is, and the pelvic tendon also of the external abdominal oblique. The linea alba should be here in the ventral midline, and you will see this picture more later. Now, another thing that I mentioned is that there is a line of separation between the muscle part of the external abdominal oblique, which is number 22 here, and the tendinous part of the external abdominal oblique, which is number 22 prime. This line is this one here, the line that separates these 2 structures, these 2 tissues, muscle part from the tendinous sheet-like. This line, especially in older horses, when these horses suffer from chronic obstructive pulmonary disease, COPD. COPD. These diseases, you will study them in medicine later on. But this is like asthma in humans, and they have difficulty breathing, especially these skinny older horses. What happened is that they start to use their abdominal muscles more frequently for respiration. Okay, and so when you have increased usage of the external abdominal oblique, this line becomes hypertrophied, and you can see it in older horses, as I mentioned, who suffer from this disease, COPD or asthma. This line becomes very prominent. You can see it through the skin, and this line, when you see it, it's called the Heave Line. Heave Line. This is the Heave Line, basically, in this old skinny horse that suffers from COPD or Heave. Now, this is basically what I wanted to mention about the external abdominal oblique by itself so far. Here we will talk about the internal abdominal oblique. Next time we will start this topic.